We're good to go?
We're good to go.
Good afternoon, everyone. Welcome to Friday Live. My name's Jane Randall. I am the Clinical Director of One Door Healthcare, which is part of One Door Mental Health, based in Sydney. And I'm also a clinical psychologist, and I've been working with people for a long time. And today I've been asked to talk to you about what the basics might be of seeing a psychologist. So thinking about that, I was thinking about what are the questions that I generally get from people in the community and from patients when they first come in. And I started to think, well, maybe we need to just think about how people actually get to a psychologist to begin with, and then what might happen for that first one or two appointments. And they seem to be common questions that I get all the time. So firstly, there are many ways into psychology, and people can be terribly confused about these, and sometimes the doctors are confused about what they need to do in terms of paperwork as well. So I'm just going to talk about those very briefly. But to be a patient and to come to a psychology practice, you sometimes need a referral and sometimes you don't. So as a private patient who is happy to pay for a session, you can self-refer, you can phone up a psychology practice, introduce yourself, make an appointment and have an arrangement with that person to pay the fee as set. Sometimes people will get rebates from their private health insurer for this, and sometimes they will just pay for their own arrangement. Many people do this. Secondly, you've got other government systems, and these tend to be the way in which we see a lot of people in Sydney at the moment. So what that means is that usually they will need a referral from a doctor, and often that referral is accompanied by something that we call a mental health care plan. So your doctor and yourself would sit down and have a conversation, and the doctor would determine whether you're eligible for a mental health care plan and what that would look like. And one of the things that the care plan might say is that you should receive psychological treatment. Now, in different areas, there are different programs for psychology services. So all over Australia, we have the Medicare program, and what that allows people to do is to access rebates for 10 sessions in a calendar year under a program called Better Access. And some psychologists will charge you a fee on top of the rebate, and other psychologists will do what we call bulk billing, which means there's no out-of-pocket expense. Other people will operate through different government programs, so they will still need a mental health care plan to see you, but they might see you through a local program that has been funded by the government in a different way. And this is where some slightly different paperwork is required. So because it's complex, the easiest thing to actually do is to ring up and identify what you're trying to do, and to speak to the receptionist at the practice or to speak to the psychologists themselves about what options are available, and then to go back to your doctor and have a discussion about that. So that sort of covers off how do people get to us to begin with. And I'm often asked the question, you know, the difference between psychology general and psychology as a clinical psychologist. And a simple answer is that general psychologists, as we call them, registered psychologists, they have a 4-year qualification plus 2 years of supervised training, and they are registered by the government to provide psychological service. The extra clinical programs require an extra 2 years at university, and a clinical psychologist tends to work with people who have either some more severe illness or might require more severe assessment, or might have a very complex medical and psychological profile. So they may have many things going on, or they may have a head injury, or they may have intellectual disability as well as a mental health care problem, for example. I've had a question here, or a comment from somebody about the 10 sessions costing $120 through a mental health care plan. So, look, I'm not sure whether that's a question or just a comment, but coming back to the difference between psychologists and clinical psychologists, there are at the moment different rates for those providers that the government allows us to charge. So a psychologist, for example, has a rebate that is slightly lower than a clinical psychologist. So therefore, if you were to agree to an appointment and the fee is higher than the rebate, then the psychologist may in fact charge you the difference. And that would be something that really we would expect someone to negotiate up front. So many of these questions are covered off when you phone into reception, and a good receptionist in a psychology practice should easily be able to talk you through the different clinicians that they have, any different price points that they have, and also different streams of income or government funding that's available for somebody who might not be able to pay extra in addition to a rebate. So that kind of covers off coming in the door, if you like, or getting to us. And then that leads me to one of the questions for today, which is what happens when people actually turn up and come and see a psychologist? So we've got, I suppose thinking about this, I was thinking, what are psychologists like? How would we describe them? And of course, going to a psychologist is going to be very much like going to a doctor for the first time. And many people start with a recommendation. So one of the recommendations might come from a doctor, and so the doctor works with psychologists that they're familiar with, that they've had good practice with, or alternatively, you might get a referral from a family member, whereby family or friends say, oh, look, I've heard this person is good, or I know somebody who's seen this person and they really liked them. So people come to us through a whole range of different avenues. And as the patient, it's up to you and the psychologist to determine if that's going to be a good relationship for you. So I've had a question. Thank you, Belinda. How would you know if you think you need to see a psychologist? Yeah, that's a good question. So coming back to my original comments about the entry points in, anybody can see a psychologist without a referral. If you're going to come in through one of the government streams, the doctor needs to develop a mental health care plan, and there are different entry points in through those streams. So for some of the streams, the person needs to have a diagnosed mental health, psychological, or even a psychiatric condition. And different government programs have different levels in terms of how ill the person is to determine their access, or their different sets of needs. So, for example, if somebody has a mild psychological condition, they might be sent to a different program than somebody who has what we would call a severe or persistent condition. So at the mild end, it's sometimes harder to know, but generally people, they feel that they're not coping. They might feel anxious about their life, and anxiety is probably one of the most common things we talk about in psychology in the community at the moment. They often might feel as though their mood is low. They might feel as though they have fallen out of interest with things that they used to enjoy. They might feel that their relationships are not very good. There might be some conflict at home, whether that be with their family members or their partner or their children. They might be starting to drink more than they would like to. A whole range of things might happen. And at this point, we wouldn't necessarily say this person has a psychiatric or psychological condition. We would be assessing them at the beginning of that process to see the impact that some of these things were having. So somebody might see a psychologist when things start to emerge, and that would be great for us because obviously the earlier someone is on that journey, the more chance we have of intervening before things get really tough. At the other end of that continuum, somebody might see a psychologist for many months or many years even as part of their treatment plan. So some of our clients who have a more severe illness will see a range of practitioners, and sometimes they'll be with me for many, many years. And I'm part of their treatment team, and I have a specific role in terms of what I do, which is different from their medical team, for example. Which brings me to another good question. Thank you, Jamie Lee. The question being, what is the difference between seeing a psychologist and seeing a psychiatrist? Probably one of the most common questions that I get. The easiest thing to say is that a psychiatrist is a medical doctor. So they have done general medicine and then they have gone on to do a specialty in psychiatry. And in psychiatry in particular, they are allowed to prescribe medications that are actually medications that are for emotional conditions and for conditions that affect the brain. So one of the main differences in Australia at the moment is that psychologists cannot prescribe and a clinical psychologist cannot prescribe. And a psychiatrist is able to prescribe And a GP is also able to prescribe some things, but a GP who's not confident with all mental health conditions will often refer to a psychiatrist if they want advice on medications. There are also some medications in our industry that can only be prescribed by a psychiatrist because they have a particular level of safety surrounding them. So, and they tend to be the ones for some of the more severe conditions. So that's a simple answer. And I'm often asked a second question, which is that should the psychiatrist or does the psychiatrist do more than just prescribe medication? And I think that comes back to the individual psychiatrist and their style. Generally speaking, a psychiatrist who works through the hospital setting or the community mental health centre may not have a lot of time with the patient to do much more than to be checking in on whether the medications are assisting, whether the person is receiving some relief from their symptoms, and perhaps whether their side effects are manageable if they're experiencing any. That tends to be what happens when the time is limited. There are many psychiatrists, though, out in the community who can spend more time with their patients, and some of them will do more of the talking style, and that might look more like spending a session with a psychologist. But overall, I find that the psychiatrists will often say, look, I'd like you to see a psychologist or clinical psychologist. They can spend more time dealing with those questions and helping you build some skills to manage things that are difficult for you. So they tend to be one of the main couple of differences. Coming back to my original brief of what might happen, I'm just thinking of a first appointment. So it's when you turn up to a psychology practice, it's very common for there to be some forms or some information for you to provide. And that comes down to what the funding body is and whether we have particular data that we have to keep in order to provide those services. So sometimes there'll be a form which has your personal details, which obviously we need to keep so that we can contact you, and we can also possibly even contact a family member or a next of kin if we needed to. Then we've got information that might be demographic information, and this is often collected by the government to see who's actually accessing these services. So you will often get asked questions about your ethnicity, for example, or your geographic postcode, your gender, those kind of questions, because often the government is asking us to retain that information so that they can capture that. Then the other thing that a psychologist will often ask you to fill in when you first come in is some of their internal paperwork, which explains what the psychologist is expected by law to do. So there are some conditions or I suppose some laws around practicing as a psychologist, and we often get patients up front to read about these and to be aware of them. So you may receive a form which sort of is like a terms and conditions or a roles and responsibilities form, and it might say, look, this is what you can expect from the psychologist. If you were to tell the psychologist that things were particularly tough and they thought that you were at risk of harming yourself or harming someone else, they might be the sorts of things that would escalate the psychologist to having to support you into a greater need of care. That might be speaking to your doctor or helping you access hospital or some other acute care situation. And obviously the psychologist is also bound by certain laws regarding some of the content that people talk to us about. So if somebody was to disclose a crime, for example, I would be mandated by law to report that through the psychology legal systems. So that should be explained to you. And the other thing that often is there on that same form is what we would call a consent form, which is that if you, for example, if you did become really unwell and I needed to speak to someone on your behalf, could I speak to your doctor, and you would sign off the permission that I could do that, or to a family member, for example. So these things are often filled in, before the conversation starts. Now, I've had a question about NDIS, which is a very topical question at the moment. So the question being, can you access a psychologist through the NDIS? And the simple answer is yes, you can. I should say up front that NDIS is actually not provided for health service. So when people are referred to the NDIS and accepted there, it is for services that are available outside of the health department. And we do sometimes have some people who have medical conditions where NDIS is not applicable, because their health can actually be managed through the health systems that are available. Where that changes is, for example, with somebody who might have very complex medical needs along with psychological or psychiatric conditions. What we might find is that the NDIS will provide some money to supplement in order to actually ask the psychologist to work on certain goals. And the NDIS and the plans that come from the NDIA are very goal-oriented plans. So what that means, for example, is a patient might come to me and the goal might be to have more solid, improved relationships in their local community or in their family. And they could choose to meet that goal in many, many ways. And the funding that is attached to that goal might be spent on seeing a psychologist, might be spent on seeing a social worker, might be spent on going to some sort of community-based social groups. And so different allocations of money can come in different parts of the NDIS plan and can be spent by the customer in a way in which they feel that particular goal will be met. So it's a little bit complex with NDIS, but certainly psychologists are one of the allied health providers who can access the funds, and they can often access it for individual counselling is one area, which is probably the most common one. And for people that have more severe needs, they can also access psychology through improved relationships or also through an area called behaviour support or intervention, which is often for somebody who might have difficult behaviours that need to be managed by other people, and so it's quite an intensive intervention. So thank you very much for that question, because the NDIS is very new to us all, and we're just learning how to manoeuvre through that system. I'm coming along the continuum and I'm thinking about what happens when someone first comes in. So we've had a conversation over the telephone. We've determined that somebody has a referral, has been assigned to a psychologist, has come into reception, is filling out some forms for that first session, giving us some data that we need, and perhaps also looking at consent forms or the roles and responsibilities. And then, of course, they come in for their first session. And what would I typically do there? In thinking about that, I was thinking that psychologists appear to be very curious people. So some may say nosy, but curious is a better word, I think. And by that, I mean that we ask a lot of questions. So we are often starting the conversation wherever the client would like to start. And we have in our mind, you know, a series of topics or conversations that we would typically have in a first appointment or a second appointment as we get to know somebody. And as we move through those particular topics, we are sort of connecting the dots in our mind to try to work out whether this person has a mild adjustment problem going on, whether there are some problems with interactions that are consistent, or whether the problem is becoming a greater problem in terms of the symptoms they're experiencing, or whether somebody's actually trying to manage a more severe illness, and we're trying to learn about that as well. So probably quite a few questions, I would think, in the first couple of appointments at least. Some psychologists are less likely to ask a series of questions and would prefer the conversation to just come from the patient. But generally speaking, most of us, particularly if we're working in a Medicare system where we know that we've only got 10 appointments in a year which are rebated by the government, and that patient may not be able to actually afford any more than 10. So we're sort of thinking we need to get to know someone as quickly as we can and try to determine with them what we both think the problem is. And then I would say probably by maybe end of session 2 into session 3, I might be thinking, well, what is it that the rest of the sessions that we have together can offer for this person? And the way that I would work, and many of my colleagues would work, is that we would negotiate that with the person. So we have a plan in our mind about what we think is happening. We have a formulation, if you like. It's a formal term for it. And we might present that to the patient, and sometimes we get asked that. Sometimes the patient will actually say, what do you think is happening? Do you think I should be diagnosed with something? Do you agree with the diagnosis that my doctor or psychiatrist has given? What sort of treatment plan do you think I need? And they're all very valid questions, and we often have that conversation together. So probably by the end of, say, session 2, I'd be thinking of having that discussion back where I'm giving a little bit of information back and probably presenting what I think is going on for that person and seeing if I've got it right by checking in with them. Then I'm thinking, well, if I only have 10 sessions potentially with this person, I'm having that conversation with them fairly early on. So I'm actually saying if we have 10 sessions and we think at this point that we might be using the first 6 to go back to your doctor to have that reviewed, and we may not have too many more sessions, or we only have 10 to work with, how are we best going to spend that time? So I would often ask the question, what would help you the most? If someone presents a whole lot of different problems in life, I might say, where do you think the starting point is? What is the problem that is the greatest for you that would help the most if we were able to resolve it somehow? Or is there an easier problem to start with so that we can start to get some confidence and get to know each other a bit? So there are different ways to approach that. And obviously, if people come in with a whole range of really difficult social problems, like problems with their housing or their finances or their family or poor health, then there are a lot of things that we could be talking about. So generally speaking, I'm trying to give them a sense up front of what their treatment plan could offer. And I think it's important to say what's reasonable to achieve within something that might only be 10 sessions in a calendar year. Now, one of the things I've noticed about NDIS is if someone has a severe impairment and has been given goals in their plan and they choose to use a psychologist to work towards those goals, then I often find you do get more than 10 that can be costed in there. So you might get somewhere more in the vicinity of 16 or 18. And that plan would go for a 12-month period. And so that might give you a little bit more scope to work on things with the client that might be more difficult to actually achieve, but you know that you've got some more sessions to do that within that time frame. So I suppose my summary is that the treatment plan and the negotiating with the client often comes down to the system which they come in, whether they want to spend all their sessions with the psychologist, whether they have additional funds themselves or through private health insurance or through family members and therefore would like more than just the allocated sessions. And I always think that the psychologist should be very, very open in negotiating that all the way through. And the patients should be advising us on whether they feel they need to see us more frequently or whether they are happy to drop back. And if I was to disagree with somebody because I felt, for example, that they were doing well, and I was saying, look, maybe we could move our fortnightly session back to every 3 or 4 weeks, and they were saying, well, actually, no, I still want to see you every 2 weeks, then that would be a discussion I would have quite openly as well. And we may make that decision based on how quickly we want to use the sessions up or whether the person feels well enough to be able to be spreading them out a little bit and working on some things in between session. Another important thing to say is that psychologists will often give you something that we call homework, but we don't really have a better word for it. But it's tasks relating to things we've talked about that are outside of the therapy session. And it's incredibly common. It is part of our assessment process, so you might find that some psychologists give you tasks that get you to think about the topic that we've talked about in the session. We often use some questionnaires, we often use diaries. There are a lot of online diaries and monitoring forms nowadays that we use, and a lot of our clients love apps, so we can often show them what are good apps to download, and they might keep some data in those apps relating to something that we might be getting them to think about. An example of this might be, say I have an anxious patient and they're not quite sure when the anxiety occurs. I might actually get them to keep an anxiety diary, and they could do that on an app, or they could do that on their phone, or they could do that through paper form, or they could send me emails where they're recording the situation and the information that relates to when the anxiety presents. And that's good for a couple of reasons. It's really good information for the next session so that we have information ready and we can use it quickly if we know that we've got a limited number of sessions. It's also really good if the client is thinking about some of the things that we've talked about outside the session. Otherwise, what we find is sometimes they come back and they say, oh, I haven't really thought about that since our last conversation. So do expect that many psychologists will give you some form of home-based activity to think about, whether that's reading or something that is a little bit more activity-based. So we've got to the point where you've come in and you've had your sessions, and that feels to me as though we've covered the basics of what to expect when you try to work with a psychologist. I hope we've understand that a little bit better today. The easiest entry point is to phone up a practice if you're aware of one, or ask your doctor for a recommendation, and to start to talk to that practice about what paperwork or what information is needed and what particular government systems would be available if you were somebody who was going to come in through one of those. If you have any other questions or comments, you're very welcome to send them through to us on the Facebook account and we'll have a look at them. Otherwise, have a fantastic Friday afternoon. I'm going to sign off. And my name was Jane Randall. I'm at One Door Healthcare. You can find us at onedoor.org.au, and we've got several clinics around Sydney and we're happy to answer your questions. Thank you.